Some patients are prone to UTIs caused by bacteria that don't grow very well in conventional conditions.
Let's move on to the topic of UTI testing, which is one of the biggest topics that we have questions on at Live UTI Free. First of all, do you think the standard urine culture can be used to rule out urinary tract infection?
I think in some patients, conventional urine cultures are very helpful, and in fact, perhaps the majority of patients. As to why some patients who clearly have UTIs often have negative results on conventional urine cultures is less clear. A few reasons that make sense. One is that some patients are very sensitive to very low colony counts of bacteria in their urine. And then another explanation is that some patients are prone to UTIs caused by bacteria that don't grow very well in conventional conditions.
Do you feel like that's becoming more and more common, or is it more that you have other tools now to use, so you're seeing these other organisms?
And that's an excellent question. You know, that refers to the possibility of detection bias. Are we really seeing a shift in UTI biology amongst patients, or has this always been the case? You know, reading some papers carefully, I actually think that there's always been this important subset of patients who clearly have UTI symptoms, and yet their conventional urine cultures are negative. If you look carefully at these papers, they'll say, oh, 20% of patients had persistent symptoms despite negative cultures, and it's glossed over, unfortunately.
Even though that's a significant number of patients.
Yes, it is.
Yeah. Do you think for some people with interstitial cystitis, there's a bacterial component?
Yeah, very controversial and very important topic. I think on both sides, there have been some misdiagnoses. I don't know how many. And by both sides, I mean that I do think that some patients told that they have UTIs have actually interstitial cystitis, and vice versa. There are definitely patients who have interstitial cystitis who actually have recurrent or persistent UTIs.
How would you go about making that distinction in a patient who is somewhere on that spectrum?
It can be difficult, and I definitely don't have all the answers. In some cases, I do feel fortunate that I think I've been able to sort it out with the patient's help. So, you know, maybe I'll start by giving the extreme, very clear examples. You know, I think patients who have consistently positive urine cultures, who respond consistently to antibiotics, clearly have UTIs. And that seems like a very easy case, but believe it or not, I've seen a fair number of patients who fit that scenario, and yet because of the recurrent nature of their infections have somehow been told by other providers that they have IC, which flabbergasts me. The other extreme would be patients who never have positive urine cultures, never respond positively to antibiotics, and have waxing and waning symptoms of IC. The classic ones being urinary urgency, frequency, and pain that improve after voiding.
What do you think about the theory of embedded infection in the bladder and how that might relate to the failure to respond to antibiotics?
Well, I do think that clearly bacteria have strategies that allow them to persist in the urinary tract, or at least reinfect the urinary tract. And there's quite a bit of accumulated data at this point, both in models of UTI as well as clinical data. So one of the major theories is that patients sometimes have biofilms
Mhm.
of bacteria in their bladders, and the biofilm, of course, is basically a slime that the bacteria can live in to hide out from the immune system and possibly antibiotics as well.
Mhm.
Now, these biofilms can either be on the surface of the lining of the bladder, and they can also be within the cells themselves. Um, the other major theory as to how persistent or at least recurrent UTIs can occur is reseeding from the gut. So there's actually fairly recent data indicating that many patients prone to recurrent UTIs have a bloom
Mhm.
of E. coli in their gut before a UTI episode, which in conjunction with older data showing that many of the E. coli strains found in the gut can also cause UTIs is consistent with the reseeding theory.
Do you think it's always reseeding in that case, or could it be the bacteria communicating with each other across organs somehow?
Well, that's a very interesting theory. Um, I'll say that pelvic organs definitely have crosstalk as it's referred to.
Mhm.
So there may be indirect communication between bacteria across those organs, since others have shown that um, your microbiome, the collection of all your bacteria in your gut, can certainly affect the crosstalk between the gut and the urinary tract.
Mhm. People also often refer to their UTI symptoms, and sometimes with positive test results too, coming on with stress, or like the bacteria just being opportunistic. They can see that something's going on and they take their opportunity to multiply. Can you explain why that might happen?
Yes, that is so. I have had patients who've expressed that this has been their experience.
Mhm.
It does make plausible sense that perhaps one could have um, a milder form of immunosuppression associated with stress. So, for example, stress increases cortisol, which is an immunosuppressive steroid.
Mhm.
Um, Now, it hasn't been studied to my knowledge, but that does not mean it does not occur.
Yeah, I think it's quite interesting the number of people who report this as a sequence
Hmm.
of events, and
Hmm.
it would be
Hmm.
great if we could do some research
Yeah,
into that.
yeah. I will say anecdotally, it also seems clear that stress in general magnifies urinary symptoms.
Hmm.
Um, how that works mechanistically, I'm not certain. That being said, I do think that many stressed out patients focus more on their urinary symptoms in general, and perhaps there's a vicious cycle occurring in that situation.
Yeah, I would say it's quite difficult not to focus on bladder symptoms, especially given the brain is wired to tell you something's going on there. Very
Hmm.
difficult to forget.
Of course.
You've spoken a lot about using urinary microbiome testing as well, to provide more insight, sometimes for patients where they test negative on culture. Do you often use multiple types of testing alongside culture, or is it always something you do independently?
So when I first see a patient, I will tend to send off um, what are called enhanced quantitative urine cultures in
Hmm.
conjunction with microbiome testing, um, which is essentially detection of bacterial DNA in the urine.
Hmm.
The reason I do that is there are a fair number of patients, in my experience, who may have negative conventional urine cultures, but still positive cultures when you do what are called enhanced quantitative urine cultures. Um, in those patients, the enhanced quantitative urine cultures, I think, are actually more accepted by the medical community than the microbiome testing,
Hmm.
because ultimately it's still growth based. Now, there's also another important segment of at least my patient population where even enhanced quantitative urine cultures are negative.
Mhm.
in which case I tend to rely more on microbiome testing. That being said, I think microbiome testing for clinical use is still relatively unestablished, and we don't know the optimal ways to interpret these results and which patients would most benefit from this type of testing.
Mhm. Do you see differences in patient outcomes across those different types of tests?
I do. And another interesting observation is that the tests often disagree.
Mhm.
It's not overly surprising because the technology that underlies each of these testing platforms is different, but it adds an extra layer of challenge in terms of interpretation of results when you have to reconcile differing findings across tests.
Do you only tend to treat things that are known pathogens, or sometimes you have to go outside that because of what you find?
Certainly known pathogens, especially E. coli in a symptomatic patient, I will try to treat. But you are correct, many times, especially on microbiome testing, more unusual organisms that are poorly characterized in general and may or may not be uropathogens do appear. And then it becomes especially challenging. The dilemma is whether or not treatment should be directed against these organisms as well.
Have you had any cases where a very unusual organism has come back on a test and treatment has resulted in improvement in symptoms?
Um, most of the time when patients have unusual organisms on their microbiome testing, they usually also have more conventional uropathogens.
Mhm.
And I try to treat those patients with antibiotics that would cover both the better known bacteria as well as the um, unconventional
Mhm.
potential pathogens.
So it would be hard to differentiate what caused the symptom relief in that case.
It can be. Antibiotics very rarely can target only a single bacteria.
Yeah. One of the questions that comes up quite a bit around the microbiome testing that is based on DNA sequencing is about the DNA itself. So, on one hand, we're often told that DNA begins to break down quite quickly once an organism is no longer alive. But on the other, we're told that they can sequence DNA from fossils that are millions of years old. So, what is the correct answer here for urine samples? Are the DNA alive, or are they dead, or can you just not tell?
That's a very important question. The underlying assumption with microbiome testing is that any bacterial DNA we detect is important, but presumably only live bacteria will cause urinary symptoms associated with a UTI.
Mhm.
Um, and so I think current testing platforms do not distinguish between DNA from live versus dead bacteria, which is a major limitation. Other fields in microbiology have shown that DNA from live versus dead bacteria do make a difference in various contexts.
Okay. And are you able to talk about the research that you're doing in this area?
Yes, so a number of years ago, another urologist interested in the microbiome questioned whether the DNA that we're detecting is from live or dead bacteria, and
Mhm.
thus if it's clinically important. And that really stuck in my head. So we're currently in my laboratory trying to develop methods to distinguish between DNA from live versus dead bacteria in urine samples and hope to do a clinical study very soon.
What's the timeline on that, do you think?
So we are actually poised to start testing clinical samples hopefully in the next few months.
Oh, that's interesting. And the results from this research, is that kind of a few years away or sooner?
Hopefully within a year we'll
Okay.
have it published, but the cogs of academia turn slowly.
Yeah, we
Um,
never
I
expect it to be fast.
That's right. I may upload it. I will upload it first as a preprint so that um, the findings are publicly available. Of course, findings uploaded to preprints are not peer reviewed
Mhm.
and should be taken with a grain of salt.
Yeah, that's interesting. We'll be looking out for that research, definitely.